everyone. I'm Dr. Shilpa Gupta, genitourinary medical oncologist at the Cleveland Clinic in Cleveland, Ohio, and thank you for joining us. Today we'll have a moderated discussion on the landscape of metastatic prostate cancer with my colleagues and friends here. And I'll start with Dr. Wee to introduce yourself.
Thank you. My name is Christopher Wee. I'm also a GU medical oncologist at the Cleveland Clinic main campus.
I'm Abdo Haddad. I'm a community oncologist at the Cleveland Clinic.
My name is Adriana Alvarez. I'm also a community oncologist at the Cleveland Clinic.
Moshe Ornstein. I'm a GU oncologist at the Cleveland Clinic.
Brian Haines, also a community oncologist with the Cleveland Clinic.
So today's discussion will be on prostate cancer, which I know we see a lot of patients day in and day out. So I'll start with, and feel free to pitch in. So the first thing we'll discuss in metastatic castrate-sensitive prostate cancer. Are you using any clinical and molecular markers for determining what therapy we should try? Because there's a lot of therapy options in terms of oral antiandrogens and CYP inhibitors. So I would love to start with Chris. Does molecular profiling influence your therapeutic choice? And when are you getting genetic testing in your patients?
Thank you. It doesn't directly influence. It's one piece of the puzzle, among other things. The patient performance status, the burden of disease, et cetera. So I do think it's important that we get the testing as soon as possible, whether that's on archival tissue or if it's bone-only disease de novo, perhaps a liquid biopsy, because we know that if there is progression, all these PARP inhibitors are on label in metastatic castrate resistant. You want to have that information at that time. So it's urgent to do it as quickly as possible. But in the terms of metastatic castration sensitive, I wouldn't necessarily wait for that information. It can be prognostic though. Certain mutations we know could be associated with more aggressive disease biology, and that may tip the scale if you're considering intensifying to a triplet. But at least everyone should always get ADT plus an ARSI. That is the standard of care at the very least.
Are you using any of the genomic markers like SPOP or anything to determine whether they should get chemotherapy or not, or you go by the clinical criteria of volume? These,
again, all of it's in consideration, is one piece of the puzzle, but ultimately, I don't have a hard. There are some patients, for example, that may have all the bad mutations. Yeah. They have high burden disease. They say you don't want chemotherapy. I'm not going to say they have to necessarily, because I don't have proof to say that it's definitely going to improve their overall survival.
Yeah, I agree with the clinical presentation is key, because it's true that we use the PSA to know what, are we in a high risk or an intermediate risk even at the beginning. But sometimes I have patients have wild metastatic disease with a very low PSA, and I have patients with significant elevated PSA, and I don't have so much burden of the disease. So I think it's the clinical presentation also, as Dr. Wee was mentioning, age, performance status, symptoms, places of So I think it's a tool, but not necessarily, in my case at least, it won't dictate what I'm going to do.
When you're doing genomic testing, are you doing germline, somatic, or both? Because per the guidelines, we should be doing, and I think it's underutilized across the US. Yeah. So what are your thoughts?
I do germline. Any patient with metastatic prostate cancer, we're ordering ourselves now in the clinic, the blood sample. And as Dr. Wee said, getting the NGS on whatever tissue you have and liquid. And I think we got into the habit, any metastatic disease, we're doing both on tissue and liquid at the upfront to know what's our option for the future. It's not going to affect the initial treatment, triplet versus doublet. That will depend on the age and performance status and the burden of disease.
Moshe, is there anything you want to add?
Yeah, I agree. I think everybody basically should get germline and somatic testing. There has been recent data about SPOP and PTEN and different mutations, and trying to figure out how to incorporate them into clinical practice. It's not standard right now, but there is data that patients with SPOP mutations may have a less aggressive disease that's more androgen-driven and can be treated with ADT and a novel hormonal agent. And maybe patients who have a PTEN inactivation might benefit more from the addition of docetaxel. I wouldn't use any of those in isolation, but I would say that taking those into consideration, if you have a patient in front of you and you're not sure, they have sort of borderline high volume disease, and you don't know whether to give them the triplet, and you see a PTEN mutation, or you see an RB1 mutation, you might be more inclined to treat them a little bit more aggressively up front, especially with the PTEN. Whereas if they don't, that might help sway the picture to doublet as opposed to
Especially
triplet.
if the patient is not very keen to get.
Right, but whether to use it as a standard of care to drive decision, I wouldn't do that just yet.
Yeah. And what's your standard, Brian, for imaging in metastatic CSPC space? I see a lot of differences in the practice patterns. A lot of people just go by PSA in HSPC, but per the guidelines, metastatic patients should be getting scans every now and then. So what's your practice?
Yeah, this is a fun question. I don't think we really know the right answer. Historically we have our traditional CT scans and bone scans, but now with our PSMA PET scan that we all love to use, how do you incorporate that into using that in terms of assessing response? Because it's not standardized. I believe the current standard is assessing a bone scan for response. I think there are some studies from late last year looking at using the burden of disease or the volume of disease based off PSMA PET scan and to assess response. So right now I am typically using traditional CT scans and bone scans to assess response, but I do get an upfront PSMA PET scan. And then upon progression, I will then repeat a PSMA PET CT.
Because it'll influence your therapeutic choice.
Yes.
Are all of you using PSMA PET scans in HSPC setting routinely?
Yes.
Okay. Instead of traditional scans?
But the burden of disease also affect what kind of staging you're gonna get for follow-up. If you have a lot of lymphadenopathy and you wanna monitor how those lymph node or liver mets, then I will get the standard CT to give me like the size and the extent. If the disease is minimal and you wanna know exactly if the activity is increasing or decreasing, then I will get the PET.
Okay.
PSMA PET.
And does that help you decide if the SUV is going low? Besides PSA, does that add any value to your?
I mean, the combination between the PSA and the PET will help me decide.
Yeah. So we have all these therapies approved for M0 space now, right? M0 CSPC, but that is a shrinking population. Are you guys seeing a lot of M0 patients now in the era of PSMA PETs? Like how often are you seeing these just PSA rising disease? Let me start with Brian. Do you?
I think it's pretty low because of the PSMA PET CT. I can think of a couple of patients off the top of my head that I do know who are slowly rising PSA, PSMA PET CT negative. But I think with the sensitivity or the ability of it to pick up early metastasis in small bony lesions over traditional bone scans, it is a smaller region. But yes, they are still out there.
Yeah, we're seeing some. We're seeing more than before.
Yeah.
Even these days, like we're seeing more in like the prostate cancer that managed by urology usually in the old ages. Now they're coming to us earlier. I don't know if I can go back to the staging.
Yeah.
Like we know how to stage, but in patient who has low volume disease, how often to stage is also another question. If the PSA is responding, should you keep doing it every 3 months or once a year, or I don't know what's your practice.
I think that's a great question. It depends on the initial volume of disease. If somebody has visceral metastases, you really need every 3 months.
Correct.
Sure. And then as they're progressing to CRPC, I really do scans because we can't be fooled by lowering of the PSA because they can get neuroendocrine differentiation with a lot of these other agents. So I would love to hear how often you're doing scans.
And no, I think there's two different reasons to do scans. One of them is for the staging up front, and the other one is monitoring of disease response and progression. I look at disease progression a little differently. I tell my patients that we're looking at the 3 Ps. We look at the person, the PSA, and the pictures. So I don't think we ever really make changes just based on a PSA or just based on the pictures, meaning the scans. I think we're using the whole puzzle, if you wish, together, looking at how the patient is feeling, what their PSA is doing, and what the images look like. I definitely like having a PSMA PET scan up front when we start treatment.
Agreed.
I think it's helpful because it gives the best look at the state of the disease. think for patients with metastatic hormone-sensitive disease, I usually just get CT imaging and bone imaging to monitor response. I generally will try to get imaging once they're PSA naders, or what I think will be the nadir. But if I see them become undetectable, try to get kind of a new baseline at the lowest PSA, and then take it from there. Upon possible progression, there I would look for a PSMA PET scan because that might change my management because patients are now eligible to get lutetium before chemo. So upfront, I like the PSMA PET scan for monitoring general response on non-PSMA directed therapy. I would get routine imaging. And for reassessment, if it might change management, I would look for a PSMA PET scan.
And I think it's a great idea to do a baseline because oftentimes we find if we don't have a baseline PSMA PET, then anytime you get a PSMA PET, they're calling it widespread progression because comparing to the conventional imaging. So, and I think, with the PSMA addition, we all saw the press release and how that will incorporate in the HSPC setting, we'll see moving forward post-ESMO. So I think it's going to become more routine to do PSMA PET scans early on.